For a long time, we've had this notion as part of national policy that GPs are involved in practice-based commissioning. And we had done that, and our GPs have been involved, but they very helpfully and assertively came to us and said, look, actually it doesn't feel like you're taking this seriously.
There are a small number of GPs who are leading the process and talking with the PCT, but I think normal run-of-the-mill GPs were not involved in those conversations.
I think there was a feeling in general practice that perhaps the PCT took decisions and spoke to them about them after the event.
GP commissioning was kind of seen as a problem, whereas actually what we began to understand is it was part of the solution.
But the board did a number of things to support GPs. First of all, we make sure that they sit on the right committees to actually share our decision making. And the board was very keen to hear directly from the GP leadership what sort of support they need, what sort of practical help they need, how do they want to move forward to engage the wider GP community.
So we made a decision that we would recruit a director of primary care development because we recognised that GPs leading commissioning was the future, and that actually this was a way of pushing forward this agenda with lots of energy.
Key purpose of my role was to take us beyond sort of contracting of a primary care service to engaging GPs in the whole system of health services, and for Southwark particularly to engage them in health and social care, because we are a integrated organisation and we really wanted to drive the benefit of that.
He came to the PBC leads and listened to the frustration and the issues, and came back really to the board with a number of concerns around finance, around data collection, and also around commissioning and commissioning different clinical pathways and how to move that on really.
We doubled the investment over the last 18 months in terms of paying for GP time to undertake commissioning, recognising it's an important job. It's not just turning up to a meeting, it's actually something that requires skills and resources.
He came back to PBC leads with a suggestion about remuneration and accountability, so that they would be remunerated properly for the work they were doing, but also that they'd be accountable to the board.
And I think the board here very quickly recognised that if we were going to have some system change, it'd be no good having a few good ideas from a small number of GPs. We'd actually have to have root and branch GPs understanding, owning the problems, and making sure that we came up with joint solutions.
As we now get into this much more formal process around getting GPs ready to take on this big role, what we've done is we've talked to them quite explicitly about their gaps in knowledge, gaps in skills and information. We've already done a workshop with them. We're planning a series of masterclasses for them, NHS finance, the nuts and bolts of commissioning and so on.
I think it's absolutely vital that we involve all GPs in commissioning. On a day-to-day basis, GPs are involved in commissioning when they talk to their patients in their surgeries, but there's absolutely no point in sitting in a room and discussing different clinical pathways or commissioning care in a different way if you can't bring the whole of general practice with you, because nothing will change.
GPs in Southwark have really been clear that they want to be mandated if they're speaking on behalf of their colleagues, so we've gone for election-type processes to ensure that's the case.
The process consists of roughly 2 stages. One is the selection stage, where volunteer GPs put themselves before a selection panel, which includes some outside expert, and those that get through that then offer themselves for election by the GPs in their area.
So we've effectively split our borough into 4 localities, and each of those localities will have GP leaders that work with their group of GPs within the area. It's worked really well to have people, representatives from smaller localities, come together, make decisions and feed it back in that way.
Since the white paper has been published in the summer, we've had an interim GP commissioning group who have been very involved with the directors from the PCT and feel on board with their knowledge about commissioning.
We're now rapidly moving to a situation where that clinical commissioning board will have delegated authority for things, and we feel that this sort of practice go or dry run has been integral to that. It's really built up that trust, engagement, understanding and an ability to take collective decisions, I think, which GPs hadn't been used to, essentially.
I think GPs have worked with the local authority on patient, each individual patient basis, but certainly not at a higher level.
GPs will be worried about how they can look after patients in the community, since part of the community care is healthcare and part of it is social care. So there'll be a lot of discussions with the borough about how that very valuable social care can be optimised in the face of a reduced local authority budget.
I think joint decision making between the local authority and GPs will be critically important, largely because of the interaction interdependency between those two areas.
We can often problem solve together very, very easily because we're a joint management team. And so I think one of the things that we're really interested in is how we can take that model of working into the new arrangements.
And I think GPs will need to get into the habit of understanding the agenda in social care and responding to that, recognising that to organisations with less funding available will really need to make the biggest bang for the local buck, if you like.
I think GPs, because they understand their patients and they understand the services, have quite a strong view of multi-service provision and what it should be. I think one of the attractions that we'll see in the GP model is GPs challenging when services are not fully provided in a joined up way, when the handover of either patients from one agency to another or their information, their records, is actually failing, and actually be able to step in and improve that.
GPs as commissioners need to work very closely with the local authority commissioners, particularly in areas like long-term conditions, where much of the care is an ongoing one with local authority.
What we've been doing is working really hard to try and identify patients with diabetes, but then to make sure that when you're diagnosed you get the right care. And actually being looked after in your local community, I think, is one of the things where we're being quite successful in terms of beginning to get people back into the community, into their general practitioners, with support from appropriate specialists.
The approach we've taken is to talk to practice about upskilling the GPs and the nurses and reviewing their diabetes care, talking to the hospitals about how we can better use their services, and maybe some of their services coming out into the community and utilising the specialist nurses and the consultants there. And I think the learning from this is involving the whole of primary care in a project has been helpful.
So that's, I think, a really good example about where involving clinicians in commissioning is getting the care pathway much better and much more in line with best practice.
That attention to the detail at an individual level is one of the things which will come with the GP commissioning model.
But I think it's very clear GPs and the local authority could make huge steps working together in addressing the needs of local people that they understand.
A small number of GPs have worked with the PCT around their governance arrangements. So I think on a small scale, GPs are used to thinking about risk and about governance, but obviously in this large consortia it's going to be a different scale.
Governance is an interesting area. It's not a fixed science. It's an area where boards do need to be reflective, always on their toes to see where new risks, the unknowns that will come, that need to be dealt with, and to be prepared to deal with those in a timely fashion. That comes partly from experience, but also from looking outwards at what might be on the horizon.
And so we've really sort of shifted around the way our governance structures work so that any major decision has to be approved by the GPs, otherwise it doesn't get approved.
I think it's important to say that GPs have been acting as commissioners together, I think, for the last 3 or 4 years pretty effectively. What we're really doing now is putting that sort of power and responsibility where the enthusiasm is.
I think the challenge for the board really is how do you develop something new whilst overseeing your own demise? And actually the sort of difficulty of that really, and also doing it with less resource and less people.
The board is still learning, but one of the key points is engagement with GP is extremely important at all levels. And certainly at the board level, GPs will, during the transition period, be active members of the board.
Some of the challenges we've faced so far are actually discussions and trust amongst the board, the directors, and also non-executive directors and the GPs, building up that trust in each other's judgment over the last few years.
We're not trying to simply get GPs to run an NHS organisation again. We're very keen on them leading the process and us facilitating that to happen as far as possible.
The second learning is to make sure that the GPs get as much support as possible from us, and the relationships we've built up with our local hospitals, with the local authority, we need to get the GPs to link into those relationships.
I think, for example, working with local authorities or even working with public health, GPs don't know what they don't know about relationships with those organisations, and we'll really need to look to the current directors and members of the PCT to help them with that.
Success will breed success, but only if it's in and feels real and is legitimate. And I think we've moved a long way in being able to demonstrate that in the things that we say and do as a board and the way in which we take our decisions.